Welcome back to the Therapeutics Chronicles. I'm your host, Momen Wali, and today marks the final episode of our corticosteroids trilogy. We have journeyed through oral and topical steroids, and now we are diving into the inhaled and other locally delivered corticosteroids. This is the realm where systemic efficacy meets local precision, a cornerstone in managing chronic respiratory and inflammatory conditions without unleashing the full brunt of systemic side effects. If you're a pharmacy student prepping for your board exams or a practicing pharmacist brushing up on guideline-directed therapy for asthma, COPD, or even allergic rhinitis, this episode is loaded with the clinical pearls and high-yield scenarios you need. From inhalers to nasal sprays, rectal foams to buccal applications, we will tackle their mechanism, optimal use, safety pitfalls, and those sneaky errors that can slip past busy pharmacy counters. Before we dig in, if you have not already joined our WhatsApp and Telegram communities, you are missing out on live case discussions, board exam strategies, and learning sparks. Check the descriptions for the links. And for my colleagues on LinkedIn, let's connect and grow together. Alright, let's begin where it all starts. Mechanism of action and why inhaled and local corticosteroids are so essential. Inhaled corticosteroids or ICS work by reducing airway inflammation, suppressing cytokine production, and decreasing mucosal edema, ultimately improving airflow and reducing bronchial hyperresponsiveness. Their local delivery targets lung tissue directly, minimizing systemic exposure. This same concept applies to other localized steroids like intranasal sprays, rectal foams, oropharyngeal tablets, and even intra-articular injections. In Canada, common inhaled corticosteroids include fluticasone, budesonide, mometazone, beclomethasone, and cyclosonide. They are foundational in chronic asthma management and are frequently used in combination inhalers for COPD. Local corticosteroids like fluticasone nasal spray or budesonide rectal foam play key roles in allergic rhinitis, ulcerative colitis, and inflammatory bowel disease involving the rectum or sigmoid colon. Let's switch gears and talk real-world application, dosing, administration, and those critical patient instructions pharmacists must master. Take fluticasone propionate for asthma. For example, the standard adult dose typically ranges from 100 to 500 micrograms twice daily depending on severity. It is usually delivered via MDI or DPI, and proper inhaler technique is crucial for effectiveness. For dry powder inhalers, DPIs, patients must inhale deeply and forcefully to activate the dose. For MDIs, coordination with inhalation is key, often requiring a spacer. Without proper technique, much of the drug ends up in the oropharynx, increasing side effects and reducing efficacy. Pharmacists must demonstrate and assess technique routinely. Nasal sprays like fluticasone are dosed at 1 to 2 sprays per nostril daily, ideally at the same time each day. Patients should be advised to gently blow their nose before use, aim the spray away from the nasal septum, and avoid sniffing hard during administration. Budesonide rectal foam is typically applied once or twice daily for a few weeks and should be retained for as long as possible to ensure local mucosal contact. With each of these products, adherence is a major challenge. These are not drugs you take when you feel bad. They are about long-term inflammation control, and patients often stop too soon, especially when symptoms improve. It's our job to educate on consistent long-term use even in the absence of symptoms. Now, let's walk through key clinical safety knowledge that pharmacists must internalize. While systemic effects are lower, they are not zero. ICS can cause oropharyngeal candidiasis, dysphonia, and coughing. That's why we stress rinsing and spitting after each use. Systemic absorption can still occur, especially with high doses, leading to adrenal suppression or reduced growth velocity in children. Intranasal corticosteroids may cause epistaxis, nasal irritation, or rarely nasal septal perforation if misused. Rectal corticosteroids can still cause systemic effects when used chronically or over large areas. Buccal steroids like clobetazole or beclomethasone oral dissolving tablets can cause local irritation or candidiasis. Contraindications include untreated local infections like oral thrush, and precautions are needed in immunocompromised individuals or those with recent nasal surgery. Monitoring parameters for ICS include symptom control, exacerbation frequency, and signs of local or systemic side effects. For pediatrics, monitor growth regularly. We should also track refill frequency as an indirect adherence marker. Alright, let's shift into pharmacist reality, common mistakes and situations that come up far too often in community and hospital settings. Case 1. A patient prescribed fluticasone-salmeterol combination via DPI is back complaining it is not working. On review, they demonstrate a weak inhalation effort. The pharmacist provides an in-person technique correction, switches them to an MDI with a spacer, and symptoms improve significantly. Case 2. A mother asks for a refill of her child's beclomethasone inhaler. You realize the last fill was over 90 days ago. This prompts a quick chat, revealing that the child only uses it when wheezy, treating it like a reliever. The pharmacist educates on the preventive nature of ICS and refers for a follow-up with the prescriber. Case 3. A long-time patient on fluticasone nasal spray is experiencing frequent nosebleeds. You ask about technique and discover he points the spray directly up the nose. You demonstrate proper angling away from the septum and the issue resolves. Case 4. A patient presents with a hoarseness and white patches in their mouth after months on high-dose fluticasone without rinsing. You identify oral thrush, initiate antifungal therapy, and counsel on proper post-inhalation hygiene to prevent recurrence. Every one of these represents an opportunity for pharmacists to improve patient outcomes and prevent long-term complications. Let me take a quick moment to remind you that if you are serious about acing your pharmacy board exams or want more real-world case-based learning, university is where it is at. Our online courses are backed with clinical pearls just like these. And do not forget to join our Telegram and WhatsApp study groups. You will find links in the description. Now, let's walk through a dream counseling simulation. Remember, DREAM stands for directions, reason, expected onset, adverse effects, and monitoring. Pharmacist: Hi James, I see you are starting on budesonide formoterol combination for your asthma. This inhaler is both a controller and a reliever. So you will take one puff twice a day regularly, and you can also take one puff as needed when symptoms flare. This works by reducing inflammation in your lungs and opening up your airways, helping you breathe easier. Most people start noticing fewer symptoms within a few days, but full effect might take a couple of weeks. You might get some dry mouth, hoarseness, or throat irritation. Make sure to rinse your mouth and spit after each use to help prevent infection like thrush. Keep track of how often you are using your as-needed doses. If you find yourself needing it more often than prescribed, let your doctor or pharmacist know. It might mean your asthma is not well controlled. And do not stop using it just because you feel better. It is a maintenance therapy. Any questions? Alright, let's look in your learning with a few rapid-fire board-style Q&A. Question 1. What is the most common local adverse effects of inhaled corticosteroids? Answer: oropharyngeal candidiasis. Question 2. True or false? Nasal corticosteroids should be aimed directly up into the nasal septum? Answer: false. They should be aimed away from the septum to prevent irritation or perforation. Question 3. What is the role of ICS in COPD? Answer: used in combination inhalers for patients with frequent exacerbations and high eosinophil counts. Question 4. Can rectal corticosteroids have systemic effects? Answer: yes, especially with prolonged use or large application areas. Question 5. What should be monitored in children on long-term ICS therapy? Answer: growth velocity. And that wraps up our deep dive into inhaled and local corticosteroids. We have now covered the full spectrum of corticosteroid delivery routes, equipping you with the confidence to counsel, prevent errors, and guide safe use. If you found this episode helpful, make sure to subscribe, share it with your colleagues, and join our WhatsApp and Telegram groups for more high-yield discussions. This is Momen Wali signing off from the Therapeutic Chronicles. Catch mistakes before they catch you. See you then.